Hello, and welcome to this continuing education course for nurses who deal with the bowel, the intestines, and with ostomies specifically. And we will be looking at adhesions as well as clearing bowel obstructions naturally. The woman on the right is the brilliant one. She's the valedictorian summa cum laude physical therapist, 52 years of experience in that field. I am a massage therapist. I had to get a license to touch. I had no intention 40 years ago of becoming a world expert in decreasing adhesions and the actual structure of how adhesions form and can deform, but have been thrust into that model and had to endure. I'd like to first congratulate all of you ostomates out there. Those of you with ostomies have endured not only the nightmare of medical intervention that brought you to the point where you needed to have an ostomy placed, but then went through one of the most invasive surgeries in all of Western medicine, having an ostomy placed. The fact that you have come from across country or other countries here and are so supportive and compassionate, and congratulations to the Ostomy Association brilliant conference here, and both you and the attendees here. I have never addressed such a fine, compassionate, and caring group, I think, in my life. Neither of us have. Disclaimer in the beginning: this is totally an educational sharing of information from 38 years of intensive study of adhesions. While we do treat adhesions at our clinics, this is absolutely not an advertisement or intended as an endorsement. We just want to give you some great information. Our focus is two parts, really: adhesions and bowel obstructions, how to avoid another surgery. And we will take a little sidebar into how to create some scientific studies for you, a little 7-minute sidebar there. We will absolutely be looking at adhesions, the structure of adhesions, what causes them to form. Is there anything we can do to get rid of them? What are the treatment options? Also, with bowel obstructions, what they are, what causes them, why are they considered so dangerous and life threatening, the second most common emergency surgery in the United States, according to JAMA Journal of Surgery, and why do they repeat? Let's start with adhesions. Adhesions are simply internal scars. When the body undergoes a surgery, an injury, an infection, any sort of a healing event, tiny strands of collagen, like the strands of a nylon rope, but microscopic, very small, but very, very strong, stronger than steel by weight, start rushing in and start laying on each other in a chaotic pattern, in a random pattern to surround the tissues that have been injured, that are inflamed or torn, and isolate them so that the white blood cells in the immune system can go to work and continue the process of healing. Okay, when they do form, they form these little glue-like bonds that isolate the injured tissue. One of the concerns is that adhesions tend to remain in place over a lifetime, so that once you have healed, those adhesions that lay down, the body just really doesn't have a way to get rid of them. And since they make a glue, if you stretch in the wrong way or pull in the wrong way and it creates some more inflammation, well, your body may bring in some more just to help decrease the inflammation in that area. Adhesions often form in the pelvis. Here we see the female reproductive system, the uterus to the far left, a fallopian tube, tiny structure designed just to carry a single egg with some few much tinier sperm in the place where life is born, the fallopian tube going off to the right there. Frequently form there, and they frequently form in the abdomen. And here are some little blow up slides of how they occur in the intestines. We'll get a better look at that in a bit. Adhesions are truly a huge problem in so many fields of medicine. After chemotherapy, after cancer, adhesions will form and prevent the chemotherapy from getting to the place where it needs to be. After a heart or a lung surgery and they close this patient up, those adhesions can continue to tighten and squeeze and constrict the structures that were repaired because they form after any surgery. Pretty much. We'll look at the numbers on that. Reproductive tract infertility and in the bowel, you have to have food go through. If food does not go through, you are going to die. So we have to get rid of adhesions in some places urgently. Uh, Here is a view of some very thick adhesions. If your doctor says, I don't want to go in there unless it's going to save your life, it is because he or she is worried about cutting through something underneath those adhesions that they can't even see. We've mentioned that they're very strong, estimated at 2,000 pounds of square inch bonds that form around joining or actually within organs, and we will look at that. What happened for us is Belinda, the blonde you saw in the beginning there, my dear wife, she underwent surgery and radiation therapy in the early to mid 80s in there. She had cancer at the cervix, which is the bottom of the uterus there shown on, and those three blue objects are stainless steel tubes and ovoids, little balls that they filled with irradiated material. So it looks like it was designed by a man, doesn't it? Inserted it surgically inside to the full depth of her uterus. They said, after surgery to this cervix, we're going to still, if there's any cancer, we're going to really get that. It is actually dangerous for us to be in this lead lined room where we're going to keep you, even though this is implanted within you. We could be irradiated just by visiting. So we can't be in this room for more than 5 minutes at a time, but we are going to keep you here with this irradiated material in you for 3 days. Oh, and in 2 weeks, we're going to do that again for another 3 days. Well, afterwards, they cured her cancer, but her pelvis was all stuck together with adhesions. She was diagnosed with frozen pelvis. Everything was stuck together. She was in absolutely profound pain. She could not walk, move, or breathe without severe pain. And she went to her doctors and she said, what am I going to do about this? I'm 32 years old. I'm ready to get married and start my life. I just can't move or breathe without pain. They said, well, we've cured your cancer. We really can't do anything about the adhesions. If we cut, surgery is just going to make things worse. We will give you some very heavy narcotics for the rest of your life, and you're just going to have to learn to live in constant pain. Well, unfortunately, surgery is truly the standard treatment for adhesions in the Western world. That prognosis not being suitable for us or appropriate, it seemed to us, we began searching for another answer. Is there a way that we could detach adhesions without surgery? Now, I was a builder earlier in my life, so I had some knowledge of structure and strength and structural mechanics. So I came into it with that, and Belinda was just brilliant woman in medicine. So we started studying these. We found that adhesions develop after 95% of all surgeries, and it is in journal after journal that they studied where adhesions or how often they form after surgery, regardless of procedure or locations. In adhesiolysis, the mildest of all surgeries, the Journal of Laparoscopic Surgery said that adhesions form in 97% of cases after laparoscopic adhesion removal at the exact site where the adhesions were removed. We can see other citations from the Journal of Visceral Surgery and Journal of Clinical Medicine on adhesion formation in the abdomen and pelvis after surgery. As we looked deeper at adhesions, we learned that what happens with these tiny strands of collagen that come rushing in, when they do come rushing in, a molecular chemical bond is formed between these strands, and that's what really kind of makes the glue and glues them together. And we started wondering, what if we could decrease or detach those bonds and kind of just pull that adhesion apart, like pulling out the run in a sweater. Well, Belinda was in tremendous pain, so we went through a period of about 3 years of intense study at medical schools and conferences and continuing ed in the U.S. and in Europe. As we took each course, we'd come back home and I would work on her and the things that were working. We started developing our own treatments around and our own techniques around. We spent 3 years doing that, and after 3 years, things started getting better. So much better that she was able to live and work without pain. And she was working 40, 50 plus hours a week and said, Larry, I don't want to do that traditional physical therapy anymore. Ice packs and heat packs and exercise, that's good for some people, but there are people around like me that have adhesions that have no treatment options. I want to figure out how to help them out. So we started advertising and treating people with mainly with chronic pain due to adhesions. And then 1989, we made an unusual discovery that we were opening these tiny fallopian tubes, the place where life is born, that get clogged by adhesions. And how in the world were we getting to that? And that it just kept happening over and over again. A couple of remarkable infertility reversals. This woman came to us. One tube had already been removed, so that was gone. The other tube was totally blocked and swollen like a lake or like a balloon inside with a substance that's thought to be toxic to baby, even if she could conceive, but she couldn't. She was refused IVF. She was so complicated, and so she came to us and said, can you help at all? And we treated her, and she had these three angels naturally. Okay. It really shocked us. Another woman came to us with severe stage 4 endometriosis pain. Adhesions form around endometrial implants wherever they are in the body. Endometriosis is the material that comes out of a woman during menstruation. It is found in endometriosis within the body, and wherever those endometrial implants land, as they swell each month, they seem to cause pain, we think, due to the adhesions that are attached to them. When we treated that, she went from severe pain to absolutely zero pain. After two failed IVFs, she came to us and had these two children naturally. So we wrote to some of the doctors in town. The chief of staff at the hospital, a surgeon and research gynecologist, called me in and said, "What is this about opening blocked fallopian tubes?" I handed him half a dozen charts. He said, looked at the first three or four. He said, "Mr. Warren, you're doing things with your hands I don't think I could do surgically, and I'm an excellent surgeon." And I said, "Is that okay?" And he said, "Well, yeah, actually, it's pretty remarkable. Are you doing any research?" No, no, we're not. Would you like to? Yes, I would. Sure, I'd love to. So we could help a lot of people, he said. Let's start doing that. I will be your research director if you like. I will not charge you anything. He is still with us. This is 25 or 30 years later. And I guess longer than that, I guess. Let's start figuring out if this can help others. So we hired two biostatisticians. The head of biostatistics at the medical school at the University of Florida had published in Lancet, Journal of the American Medical Association, all the big ones. And Amanda Rice, Dr. Rice had a double PhD in histology, what occurs at the cellular level of the human body, and also in disease modeling, how diseases start, how they grow. So she seemed perfect for looking at us in their situation and seeing what we were doing inside the body and trying to answer some theoretical questions of what was happening. They had us do some uh, objective tests where we took this woman where if you those of you who aren't used to looking at x-rays, we'll talk about this for a second. On the far left hand side where there's an upside down R, you'll see a little line going up beside it. That's a catheter, a straw, feeding a white dye. It shows as white in these x-rays inside into this woman's uterus. It fills her uterus, and that's the interior of the uterus, the big white space. It looks like an upside down A, I guess, or an upside down rocket, because at the very top are the fallopian tubes, where the fallopian tubes start. Does not go through the left one at all. It goes through the right one a little bit. You can see it kind of trickling down, but really doesn't go all the way through before we treated. After we treated, there was free flow of the out of the fallopian tubes, shown in those green circles, and it just came pouring out. And she had two children naturally after we treated her. May have had more. We haven't been in touch with her since. After looking at this, we noticed also that we were not only opening those tubes, our original intent, but beforehand, her uterus was constricted or squeezed by adhesions. She had had surgery. We did not see adhesions from the outside, but they must have been in the vaginal wall, because after we treated, it looked like her uterus probably looked when she was 12 or 13 years old, just uh, no adhesions at all. Certainly a much more hospitable place for implantation, much more relaxed, and so probably part of the reasons that she had two children after we treated her. So we realized we were not only opening blocked fallopian tubes, we were likely decreasing adhesions in the walls of her organs. So, in the walls of her uterus, in her case. Now, for those of you who deal daily with medicine and with patients, it can happen to you that you sometimes notice some remarkable results. And you wonder, where did that come from? Is that something that I can reproduce? I'd like to be able to document that, and I'd like to, it's just so unusual. I really want to know more about that. This happened to us occasionally in this because we were decreasing adhesions in different parts of the body. This woman called up Belinda one day and said, I'm having orgasms like I've never had in my life. Belinda said, very appropriate. Are you okay? Is that all right? She said, well, yeah, I'm fine, but I mean, these are real toe curlers. These are remarkable. So remarkable, I felt like I had to call you. So we got word of this and got other calls from about four or five other women along the line, and we wondered, why is this happening? Are we perhaps freeing adhesions from vaginal walls? We know that non sterile objects are entering a woman in her vagina into a sterile environment, a place for life to grow. If bacteria get in there, you go, wow, this warm, moist target's perfect place to grow. They grow and adhesions form in there. We were treating internally, some because we're treating female infertility, and we were wondering if we were treating freeing adhesions there. You want to know when these kinds of things occur. You see some or hear some unusual positive results from your patients. Is this real? Can I repeat this? Will this possibly be able to help others? You want to be able to document this and maybe see if you can help others and possibly win a Nobel Prize. A Korean hospitalist, a physician from Washington State, brought his mother to us in Florida from Korea. And while I was treating her, it was for recurring bowel obstructions. While I was treating her, he said, "You know, you should win a Nobel Prize. We've had actually three doctors say that." I said, "What do you mean? I'm not a doctor." Yes, but you'd realize that the person who won a Nobel Prize for discovering that ulcers were formed from bacteria was a lab technician. It was not a physician, and he won a Nobel Prize, and you can win one. So follow this up, and maybe you can figure out a way to win a Nobel Prize yourself. If it happens for us, I know it'll be way posthumous, and I don't really care about that. I just like helping patients. So in order to figure this out, you have to follow what is called the scientific method. And I'm going to go through that for you and explain it in really simplest terms. You want to document your positive response, and it generates a question. Is it real? Can I repeat this? Theoretically, if you want to certainly know why it's helping, but at this point, that's not important. You just want the facts. One of the ways to generate facts is to get before and after data. In order to, if you're going to eventually think this is good enough to publish, let's involve an IRB. All hospitals have an IRB, an institutional review board that is there to monitor for patient safety. If you have to hire an independent IRB, they're about $1,000 a year for the least expensive that we could find that were reputable, and um, they're you can find those. So that $1,000 is good for about a year generally. And then you have to do it again if you still need another one. But past that first year, you want to get some objective before and after data. If you can get objective tests like we had, where there were X-rays that are indisputable, that's the best. But other than that, you can create your own before and after questionnaires, and those can be used by a biostatistician to discover just how good your treatment is that you are investigating. We're going to look at the frequency and intensity over the last 30 days of whatever this patient experienced that is changing. The frequency we will look at is can be as simple as never to always. It could be half the time, less, or more than half the time. So there's 5 different areas of frequency you can ask them. And the biostat can actually put those into columns and be able to calculate data as far as any changes in frequency uh, before and after the treatment. You're going to want to look at the intensity. What was your worst pain in the last 30 days, 0 to 10? What was your average pain? Okay. With pain, the drop of 2 is considered significant and publishable. If a 30% drop or a 50% drop, for example, in frequency, would be substantial. Okay. Any of those are mean that you can publish that. Okay. In our particular case, in this group of patients, Dr. King insisted that we conduct a study on sexual function because we were getting so much positive response. We asked questions like, "How frequent do you have intercourse?" Or "How frequent do you?" And certainly, "How frequent do you have orgasms?" And "What is the intensity?" And "What about pain levels? What is the pain level from never to always or sometimes?" The intensity, the FDA scale of a 10 pointer, actually it's an 11-point scale because it's 0 to 10 is 11 points. And then you might ask other questions. In our case, we asked, was the pain at the entry or with deep penetration or both? Then you give that data to your biostatistician. Hopefully, you can find one who so likes you so much and is so interested and would like to be on there as an author that he or she will give you results at no cost other than that you have to hire a biostatistician. And once you have those biostatistical results, you can report them to the hospital board. You can send them as an abstract to different conferences depending on what area you're dealing with, whether it's gastroenterology or uh, cancer or whatever. Just look at those societies and submit your abstracts, and they will choose the ones that they like, and they will publish them, the abstracts, in their journals, and they'll look to you to continue that study and to write up a full study if you like and submit it to that journal. uh, as you move along in the scientific method, you're going to move from retrospective, where you first notice something, then you try it with several people, to prospective. Let me ask the question: can I increase sexual function? Can I decrease pain? Can I in this by using whatever you're testing? And those prospective studies, and then eventually getting into a controlled study where you take a group of patients that did receive your intervention and compare them to a group that did not receive your intervention, or that got a placebo, or they could just be treated and not treated. That's fine. And you can create a controlled study. In our case, we did all of this, and we found that we improved sexual function. Reduced intercourse pain was the big one, 90 and 96% of patients. Increased orgasm, the lowest was 56% of patients, and then improved desire, arousal, lubrication, satisfaction. These are actually six well-defined domains of sexual function, and published it in WebMD's Medscape General Medicine, edited by Mr. Dr. Lundberg, who edited the Journal of the American Medical Association for 17 years before he took over for WebMD. We also improved sexual function for a group that we pulled a group out that had history of endometriosis. So, and we were able to publish that in the Journal of Endometriosis. And very similar results you will see there. A little bit higher, perhaps. Um, Not quite as high with pain, but still 93%. That's pretty dang good. And decreasing pain with endometriosis, we thought, well, we'll throw in a question there about period pain. And we had decreased period pain in so many of the women in our studies over the course of time, just from that one question. And then the other things that we investigated, we published in journal after journal documenting our results. And so that'll take you through. And if you ever need help in this, just give me a call, and I'll help you walk you through. If you have some discoveries you'd like to investigate, call me. Okay? Let's look now at bowel obstruction. The first thing that happens when a person has a bowel obstruction is they have terrible pain. You're just writhing on the floor. You know that no matter what, you just have to get to an emergency room. There's nothing else you can do. You go to the emergency room, they say, okay, you're going to be with no food or water because nothing's going through you anyway. We don't want to pile things up in your stomach. We'll give you IV hydration, some pain medication, and nutrition will all be intravenous. We are going to put a nasogastric tube into your nose and feed it down your esophagus and into your stomach and leave it inside of you until this hopefully clears. So that's going to pump out any excess stomach acid or contents um, while you're waiting. And how long am I going to wait here? I mean, my life was going along, and suddenly I'm in the hospital. What's up for me? Well, it's going to be the average hospital stay is going to be 5 to 10 days. Okay, if it clears on its own, which is possible, your average stay is 5 to 7 days. If you're going to have surgery, the average stay is 10 days. After surgery, you have to recover. It is a major surgery, uh, and you're going to be recovering for several weeks. So as you're lying there, your life is totally on hold. You're wondering, am I going to be discharged? Am I going to have surgery? Am I going to die? I mean, this is really kind of scary. It's very uncomfortable with that NG tube in your nose. And the patients that we know who have had multiple bowel obstructions, and they do recur, unfortunately, is they do advise, well, you can always ask for a pediatric uh, NG tube if someone ever says they're going to insert one. It'll do pretty much the same thing, but it's a bit more comfortable than the adult NG tubes. So the results are at the end, it clears. Okay, it cleared on its own. That's great. I'm discharged from the hospital. I can go home. That's wonderful. However, the doctor reminds me structurally, nothing has changed. It's just finally enough moved that food went through. The whole process can recur at any time next week, next month, next year. The other thing that can happen is it doesn't clear and you have surgery. So you have the surgery, the doctor says, I managed to clear the obstruction. Oh, that's great, doc. Thank you so much. I'm really looking forward to getting home, getting back to my life. Yeah, that's fine, but I do need to remind you that surgery is the number one cause of bowel obstruction. New adhesions can recur, and probably will recur, and this whole process can recur again. So you're walking around in either case with this heavy weight, this anvil over your head, thinking, what am I going to do? I mean, it's kind of scary that this whole thing could happen all over again. It's been a nightmare, frankly. Here we have an image of what a bowel resection might look like, where the right hand is holding a piece of bowel that is being removed. The left hand is holding part, and there's a little part coming up from the bottom that is going to be rejoined. There's an instrument where it's starting to rejoin those two, and the surgery itself is pretty complex. It is the second most common emergency surgery in the U.S., JAMA tells us, and has the highest complication rate, 47%. Why? Because if a drop or two of the bowel contents spills out into that dark, warm interstitial space of the body, bacteria tend to grow and proliferate, and 3 or 4 days later you're in great pain again. You have peritonitis. Now we're going to have to open you up again with a full open surgery, pour antibiotics in there to kill that bacteria. So 1 out of 5 people return to the hospital within 30 days. Either that has occurred, or sometimes if the adhesions are so thick that the doctor can't see where he or she is cutting, might inadvertently cut through your bladder, your stomach, your another organ, or the intestine. So it's a complex surgery. The primary cause of small bowel obstruction is universally recognized as post surgical adhesions. As a matter of fact, we've mentioned it's the second most common ER surgery, and adhesion removal is actually the fifth most common ER surgery. When we started opening, wondering, well, if we can open these little fallopian tubes and we can help in areas like the uterus itself inside the wall of it, could we possibly open larger tubes for patients that are suffering with recurring obstructions, like these life threatening bowel obstructions? And we'll take a look at what those can look like. On the left, we have a stricture, a narrowing, and there can be adhesions on the outside. So often with strictures, they are actually inside the wall of the intestine, narrowing and squeezing it together like an hourglass or worse. And we'll see that. Here's some artist depiction of some adhesions in the intestines, and also an image of a huge amount of intestines that are just all stuck together from adhesions. They should be able to slide and glide over each other easily. All of our organs should, and when they become stuck, it causes problems. Here is a close-up slide of a stricture. That mechanical device there that that doctor is holding is pointing right at an hourglass restriction. You can see that bowel narrowed down to almost zero, an hourglass stricture. You don't really see much in the way of adhesions on the outside. There's some to the left of that scissors or that caliper, but they're within the wall, and an artist drawing of how he or she thinks that adhesions form. In our case, we started testing this. Here's a patient who was scheduled for surgery, and in this patient's case, the bowel was filled again with a dye that comes out as looking white, and there's a large white area, like a C shaped backwards C, behind that arrow, and the dye is going through really well until he gets to the tip of that arrow, and it's just an hourglass stricture. It is so totally narrowed down. The doctor said, "We're going to do surgery. We need to do it very quickly." That patient was already scheduled for clear passage. After we treated her, that's what the bowel looked like on the right afterwards. It was wide open. The doctor said, "I'm not doing surgery now. That's normal bowel. I don't have to do any surgery. That would be unethical, and there's no reason to. It's normal." Remarkable. In an even more remarkable case, this patient had a stricture 6 inches long. Her intestine looked like a coffee straw. Nothing was going through there. No food was going through there. Liquid. The dye could barely squeeze through. Just a little uh, bulb, something the size of the lead of a pencil, I guess, was of dye was going through. Absolutely going to emergency surgery. We again treated the patient before surgery, and after we treated, the doctor said, "Looks really good. I mean, it's not, there's no reason for me to do surgery there. It's not quite as large yet as all the rest. We might want to do a little bit more, but it's just, that's now normal bowel. I'm refusing to do surgery. There's no need for it. I'm not going to do it." So that was pretty remarkable to us. We know that bowel obstructions recur 34 to 42% of cases after surgery, according to the Journal of the American Medical Association. Lifetime Archives of Surgery says they recur in 53% of patients. A surgeon from Harvard, up at Mass General, was sending us patients that were so complex she did not want to do surgery. She was afraid she would cut through something. She said, "Can you possibly stop the recurring obstructions? Let's design a study." And we took patients who had recurring obstructions. We took two groups. Each group had over 100 patients in it. Each one was having recurring obstructions. Half of them we did not treat. They were the control group. The other half, which actually had much more complex histories of obstructions, we treated. And we compared the two at the end. And at the end, with over 100 patients in each group, which made it a phase 2 study, a large study, which is much more significant. Those who we did not treat, about 15 of them had another repeat obstructions. Those that we did treat, only one out of over 100 had another total obstructions. So we reduced recurring bowel obstructions by 15 times the norm. The p-value there at the bottom, the probability of this occurring just by chance, this is what biostatisticians come up with, is 3 out of 10,000. So very high probability and reputable results. We do have some free downloads for you here. They have a book and a video and a diet guide. The book is about adhesions. It's absolutely free at the website. Amazon made us charge something in Kindle or paperback, so we charge the very minimum. If you want to know more about adhesions, you can get that book. If you have or know someone who is obstructing, even in the hospital, and they just want to get out before surgery, have them look at this video that our brilliant physical therapist, Sharon Hepburn, in St. Louis, she was at Washington University in St. Louis, created this video for you. We looked all over the U.S. for a dietitian who knew how to advise diet for people with bowel problems, especially adhesions in the bowels. And we could not find any. We finally developed our own book, used the Canadian Department of Health, because the AMA guide for diet is, generally speaking, high fiber, and fiber is the worst thing for somebody with an obstruction because it all clumps together and makes a cork. So we created this diet guide. It will give you a sense of what it's okay to eat and what you should avoid. Belinda actually made a chart that's where you can see where you are and what you're eating now. And if you want to test the waters and eat a little bit uh, wider variety, how you can go up a level, down a level. Or if you need to lighten up a little bit, you're having some problems, how to change that. So all of that we have put on our website for the 30 or 60 days after this conference. These will be accessible at our homepage, and it's going to be a little box like this where you can click the things on the right to get that information. That will also be on our bowel obstruction page, but they will be there nonetheless. These little quick links are only going to be up for about 60 days, but they're on our website. So many physicians asked us to explain our work to them that we made a 40-page booklet for physicians, and you can download that, or we'll be glad to send that to you. I want to thank Belinda, and I both want to thank each and every one of you for coming. We hope you have learned a lot. We wish you the best of health. We salute you again for the nurses, for your dedication in doing and working with this group, to the people that organized this ostomy conference. Just so well done, so professional. And to those of you who have ostomies and have sloughed off being just upset that you have an ostomy and are going ahead and finding your life after going through the nightmares of the what brought you to an ostomy and then having an ostomy, but are moving forward with your lives. We thank you all and salute you. Thank you.